Hiya there. Right, I'm Catherine Common. I just wanted to welcome everybody to this webinar today. So we're having a little trial of seeing whether this works. So this is our first webinar. We did obviously have another couple scheduled a few weeks ago, but unfortunately we weren't able to let those go ahead. So this is the first one that we've actually done. So I've got Joe McDonald and Louise Wilson who are sort of joining us today. The point of this webinar is for Joe to give an update on the Great North Care Record, to talk through where we're up to with the programme and sort of what the sort of future direction is for the Great North Care Record. So really this is just an attempt to see if this works. There's lots of things coming up this year, and there's a huge amount of pace and progress going on with the programme at the moment. And what we wanted to do with these webinars was to just sort of keep people up to date and just use another way of sort of communicating with people so that you know what's happening. So the format for today is going to be a short presentation with Joe, and then we'll just be doing some questions afterwards. So you've got a chat feature on the computer there, and we've also got a Q&A. So if you want to send any questions through, they'll come through to me and I'll put them to myself, Joe and Louise sort of after he's done his presentation. If we get too many questions and we can't deal with them all, we'll take it onto discourse afterwards as well. So I'll hand you over to Joe, who's going to take you through his presentation.
All right. Hello, everybody. I'm unfamiliar with this technology, but we'll see if it works. I'm hoping that I can move the slide on with a simple push of a button, and I can. A little bit of history about why Great North Care Record. I'm a child psychiatrist by background. I have 30 years in that field. Most of the latter part of it has been in the treatment of young people with psychosis. Psychosis is a dreadful condition, can be lifelong, and affects young people at a key period in their lives. So when I got a phone call a while ago from an old friend from university telling me that his daughter was having a first episode of psychosis, and he asked me the not unreasonable question, Joe, what's the best treatment for my daughter's psychosis? I had to tell him the truth. After 30 years in the game, I don't know the best treatment for your daughter for psychosis. I'm pretty sure that it'll be encoded somewhere on a genome, which antipsychotic medication she'll respond to, and I'm pretty sure that if I get it right first time, she'll be better in 6 weeks, back in school, maybe go on to medical school and have a great life. If I get it wrong, because what I'm doing is I'm picking the medication by lucky dip, I can't link the genome to the right drug at the moment, it could take me anything up to 2 years to find the right treatment. That's probably going to be 2 years in a psychiatric institution and a developmental trajectory which follows an entirely different path. So what we need to do is to be able to use data that's currently siloed in electronic patient records to find out things like what is the best treatment for psychosis. So that's why I'm involved. How do we liberate data to answer those big questions? Well, we decided, having looked around the world a few years ago at integrated care records in New York, Northern Ireland, Hampshire, that actually what we needed in the Northeast was a means to liberate the data that's already there, 30 years worth of data in the GP record, for example. The most successful electronic patient record system in the world is the GP records in the UK, but the data is largely siloed. We looked at all the information sharing projects going on around the world, and we decided we'd build one of our own, and we came up with the concept of Great North Care Record. It was a concept developed by a number of clinicians in the Northeast, and we decided that we wanted to deliver a couple of key ideas. And one, we wanted to make it the best place in the world to get care, so that we can deliver your important information to the point of need wherever you are in the Northeast and North Cumbria. And also, we wanted to be able to be the best place in the world to do research. Fairly lofty ambitions, but they're in the great tradition of science and engineering in the Northeast. So we set out to build that trusted brand and a clear vision. We got a head start with some money from Connected Health Cities. Thank you, George Osborne. and that allowed us to get started. The scale of the project, we've got 3.6 million citizens, 350 general practices. This slide's slightly out of date. It was 2.5 STPs. It's now one ICS, Integrated Care System. We're coterminous, thank God, with our fabulous AHSN, Academic Health Science Network, and that's been key to our development. We cover 9 acute trusts, we have 3 mental health trusts, and we have 7 local authorities, all keen to be involved. In terms of the technology that we've got already, in terms of EPRs, electronic patient record systems in the Northeast, we've got a perfect storm from an interoperability point of view. We've got one of everything, at least one of everything, and consequently, the option for us to rip and replace all those systems and just have one system to allow that information sharing isn't an option. We can't afford it, and too many of our local organisations have invested heavily in these systems, and we need to make them talk to each other rather than just adopt one. One of the challenges that we face is around privacy and concerns around access to information, and even just during the history of this project, which is about 4 years old now, the mood music has changed. Back in the day, let's say when the summary care record was hitting the headlines, it was around 2% of people who wanted to opt out of that sort of thing and who were passionate about privacy, and who actually showed up some pretty poor practice at a national level during the National Programme for IT. Recent times, we've had scandalous behaviour by Facebook and a lot of subterfuge around the sharing of information. The public are increasingly interested. We used to talk about 2%. I think it's much more than that now. People who are worried about this kind of thing and how their information is shared. So we talk about the people who are passionate about privacy, people like Big Brother Watch, and organisations who are concerned with privacy. We need to look after them. They're actually the canaries in the information governance mine. If they're telling you your project is in trouble from an IG point of view, they're often annoyingly right. So we do like to make sure that we've looked after the people who are passionate about privacy. So we need to do a big piece of engagement, and these guys have been helping to do that big piece of engagement around clinician engagement, and in particular around citizen engagement. We like to think of ourselves as a citizen-led project, and we've worked really hard to make sure that we're taking people with us. This is the wall of the office of Great North Care Record. We call it the Wall of Love. Along the top, you've got key roles, so chief executive, CCIO, CIO, directors of finance, etc. And down the side, you've got the names of the organisations, and in the middle are the names of individuals. Wall of love, because all of these people have to love the project in order for it to go. It's a massive stakeholder engagement exercise, which has there's no other way to do this. The technology, frankly, is not the hard bit. The hard bit is the wall of love and getting everybody on board with such a big sharing project. We've been blessed and fortunate in a number of ways during the course of the project, not least when we discovered the information sharing gateway produced by the good people of Cumbria. This is a gorgeous tool which allows us to do information sharing agreements at an unheard of scale and pace across the northeast and North Cumbria, and it's basically it's like joining a club. So you get a username and a password to join the gateway, and when you log in, I can see all the local organisations, so Newcastle University Teaching Hospitals, NTW NHS Trust, City Hospitals Sunderland, the QE in Gateshead, and if I want to create an information sharing agreement with them, I just tick the radio buttons. Oh, and 350 general practices as well. And there you go. So we've been able to get those information sharing agreements in place thanks to our brilliant information governance community who've put that together. So I know that that's taken off in other parts of the country, but it has made it possible for us to do information sharing on a 3.6 million citizen scale. So phase one of Great North Care Record, not massively technically complicated. As I said, it's a sociological issue for the most part, but we have managed to share the GP record using MIG, the Medical Interoperability Gateway. It's been developed by a clinical network who've led that. We've embedded MIG into EPRs where we can, so the clinicians in secondary care get one-click in context launch out of their EPR and to get a view of the GP record. And all those information sharing agreements whirring away in the background. Every dot on that map is an organisation sharing information to make patient care safer. We've run a massive citizen engagement project in conjunction with our local Health Watch organisations, and we've looked to co-produce and co-design a model of consent around regional sharing, which includes citizens' willingness to be contacted and involved in research. And by that we mean it isn't just about doing perhaps what's been done in other areas. Interestingly, actually, when we spoke to the people who run the New York e-Health Collaborative, and I asked the chief executive, Dave Whitlinger, what he would do differently about the 8 million records that he's got in the New York e-Health Collaborative, and he said, I would have collected people's consent around research, and then we could have been the most powerful research organisation in the world. But unfortunately, we didn't do that. So right at the outset, we thought, well, what if we did that? What if we actually collected those permissions? And we've been working with the citizens, 25 workshops, 500 citizens, to come up with a way to get them to record their consent around using their identifiable data for research. Can we ring you up? You've got an interesting genome and we can see you're on an antipsychotic. Can we put all that lovely data together and answer some of those basic questions? What's the best treatment for schizophrenia? What's the best treatment for breast cancer? So something that most people had filed in the too difficult box. And when we spoke to citizens actually and had a conversation with them about it, they got it. And for the most part, they're willing to volunteer their information on a regional basis for the good of the North East and North Cumbria. So we talked initially about consent-rich research environment, and then GDPR came along, and then we're not allowed to talk about consent anymore because it gets confusing. Unfortunately, the public still use the word consent to mean what they think it means. So if you're engaging with the public, we do have to speak that language, even though it gives the IG crowd the collywobbles on occasion. But we still have to use it when we're engaging with the citizens. Hopefully we'll move to a situation where we talk about a permission research, easy for me to say, a permission-rich research environment. So we produce that unique environment in the North East and North Cumbria. So we built a little consent model, as I say, have been filed in the too difficult box, and yet every other industry, every other organisation in the world pretty much has found a way to collect your preferences around privacy and sharing. Are we any different? We don't think we're all that different, actually. When we ran it past people, they thought it might work. We have, in fact, now tried this out in a group of patients for real, and we're getting an opt-in rate of around 88% to use their identifiable data for research. Now, received wisdom in the past was that you couldn't get people to opt in. I think something's changed. People are now so used to recording their privacy preferences that it's quite normal for people to opt into things. So I think that game may have changed. I think we may have proved that it has changed. We've been blessed with our new Secretary of State, Matt Hancock, and his new technical vision, all of which we entirely buy into. Cloud first, internet first, interoperability. Well, we had to do that in the North East, North Cumbria anyway. Matt Hancock has been up to the North East and has heard about what we're doing. and I think everything we're doing is fully on board with what he's trying to do in terms of shaking up NHS IT and pushing it forward at a rate of knots. Politically, we're poles apart, but from a health IT point of view, I think he's a real deal, and I think we can make some progress. How are we going to get the money? Well, it's raining money, people. You know, there are all manner of government money coming. It's not terribly well coordinated. It comes out in different silos and from different parts of the system. But there's a program called Local Health and Care Regular Exemplar, which might bring in $5.5 million if we're a successful applicant. There's health system-led investment, which is, I think, to try and improve the digital footprint of our integrated care system, the ICS. And much of what we're doing in Great North Care actually should pay for itself. And if you think about it, you probably shouldn't be doing it unless it's going to save money or improve care. We think it'll do both. Slight problem with some of the money, and I won't apologise for having a whinge about this, because the government needs to change this actually. When the government give you capital, effectively it's a loan, so you have to pay capital charges on it, and then it's then quite difficult to get a host organisation, let's say the NHS Trust, to pick up that capital on behalf of the region and then have to pay charges on it for a benefit that everybody else is getting. So you've got to find a way to share out that pain. It would be nicer if some of that money came through as revenue, because in a cloud-based world, we're not buying tin. You know, we're not building motorways. We're building services. So apologies for the whinge. Just to think about what data is worth at the moment. An organisation called Flatiron Health were acquired by a drug company called Roche recently in the United States. And they paid $1,000 per patient record for 5 years of data. That's what a patient record is worth. And that's just 5 years of data. But that was the going rate in a recent transaction. We've got 30 years worth of data sitting in the Northeast here, 3.6 million records. Do the maths. The data is worth $21.6 billion. That's just the worth of the data alone in the Northeast and North Cumbria. So if we can't make this pay for itself, we're missing a trick somewhere. I should say at this point, we're not about to sell your data without your permission. That's not what we're about. Our approach has been informed by scouring the world for the finest minds, and one of the finest I've met is Professor Margit Annestad from Oslo University, and I went out to see her a while ago. There's a little link on the bottom of this slide, 15-minute video on what's the difference between a successful information sharing project and a failed one. And we have very much taken this to heart, and we will be following the Margit Annestad approach to developing the Great North Care Record as we go forward. Crucially, she talks about you need to cultivate something. You can't engineer the whole thing in a top-down manner. You have to take what works and build on it, start small and grow it, and you must take a modular approach so that if a bit of your project doesn't work, you can bin it and you can bring in somebody else who might be able to make that module fly. You've got to build on your installed base. She's written a very good book called Working with the Installed Base, which I thoroughly recommend. And our installed base is the plethora of systems that we've got. It's got to be clinically led, and it's got to deliver early clinical gain. If the clinicians lose interest in your project, it will very quickly die because it doesn't deliver for them. And if it doesn't deliver for them, it doesn't deliver for anybody else. Not least, it won't deliver any data because they won't record anything in it. And you've got to build trust. The bit about developing trust is absolutely key. As I've said, the technology isn't the hardest part. It's the sociology, it's the bioethics, and the anthropology. Actually, we've got an anthropologist, a sociologist, and a bioethicist on the staff. We never did that during the National Programme for IT. It was just clinicians and techies. And we never fell down on clinical or tech. We always fell down on ethics and anthropology and sociology. That is a key message I think we need to embrace. So we've been cultivating the Great North Care Record for getting on for 4 or 5 years now from its inception, and we're ticking our way through these 9 boxes, and we're getting pretty close to achieving what we want. We've got the networks built up, the CIO and CCIO networks. We've got all our chief executive community on board. We spent a lot of time writing the specification for Great North Care Record. We secured local funding. Thank you, our GDE community. Thank you to the AHSN and everybody who's been involved in getting us to where we are. And we are developing the 3 modules as Marginalist outlined. First one is a health information exchange, and we will be announcing in the next couple of weeks actually who we're partnering with to develop that health information exchange. The work on the specification has been led by Graham King, the CCIO at Newcastle University Teaching Hospitals, and his team, and they've also led on the production of a specification for our second element, the patient engagement platform, and we will shortly be meeting with our regional stakeholders to look into the third element, the third leg, if you like, of our 3-legged stool, the Great North Care Record, is a population health management system / trusted research environment. So they will be the 3 parts that will constitute GNCR. There's a lot going on at the moment. We've just heard the announcement of NHSX, which is the drawing together of some of those silos in which health informatics is currently born out of NHS Digital, NHS Improvement, NHS England, and Matt Hancock has recently announced the pulling together of those organisations into a single body who will oversee the development of NHS IT with a clearer outline about who's in charge, and maybe unsilo some of that money and change how we do things. I've just got back from the United States, where I think I've seen some of the future around. Much of the talk in the US is about Facebook and about Google and about the theft of citizen data, and there's a great movement growing in the United States around citizen-centric EPRs, around patient control. So New Hampshire have just announced, for example, that the patient is the owner of the EPR. It's not the hospital, it's not the state, it's the patient is responsible for the ownership of their own data, and they get to decide who sees it, who doesn't, how it's shared. Oregon are about to follow suit, including actually your anonymized data won't be shared without citizen permission in Oregon, and that movement is clearly picking up pace at that conference. It was very much the buzz. I expect that to come here. We're hoping that with our approach to citizen involvement that we can stay ahead of that game rather than get taken down in a care.data style by another moral panic around IG. So I think those are highly relevant to what we're doing. We've made tremendous progress this year in terms of our HIE will go live this year. I expect at the latter end of the year we'll have our patient engagement platform will also be up and running. All of this is going to take the solution of what Marginalist calls the solution of a collective action dilemma. If we all act together, we can produce something marvellous. But many times the system is set up actually for us to put us into competition with each other. That's got to finish. We've got to find a way to subscribe to GNCR. We've got to find a model for making it work as we go forward, not living on capital grants, hand to mouth, as it were, from the government occasionally. That won't work in the long run. So we've got to stand up a subscription model. And while we're waiting for the NHS's latest revolution, in terms of its reorganisation, we need to come up with a vehicle to take GNCR forward, and that needs to be something that's wholly owned by the community in the North East and North Cumbria. And we will again be making announcements in the next few weeks about what that vehicle will be. I've said this is very much an engagement-led project, and we mean it. That's not just words. We do need you to get involved. If you'd like to be involved, we have an online forum where you can, have your say, complain about stuff, put your two penneth in about what you think should go first into a health information exchange on a platform called Discourse. If you contact us either via Twitter at Great North Care or via me, our email, not really me, somebody else will be opening that and doing all the hard work. If you've met me, you know that's the case. But we'd love you to get involved in the further development of Great North Care Record, because it is genuinely needs to be co-produced. And I think that's all I want to say. I've probably missed out loads there. You want to add anything?
Well, I mean, we've got quite a few questions there, so we can go through those.
Cool. There's actually people there.
There's actually people have sent in questions. I think there's a couple of things I want to mention, certainly around Discourse, what we'll do, because I think probably most people that have joined this are probably on Discourse, but if you're not, yeah. I'll send the link out to everyone. So if you're not a member, then you can join. And we'll also send out the slides as well, and we'll put the link to Margaret Anastad's video on there as well, so you can watch that. So I'll just take a few questions on here. They're all coming in thick and fast. I don't know whether we can answer them all, but we'll have a try. Well, and if we can't answer them, we'll put them on Discourse and we'll get someone who can answer. So I've got the first one here from Phil Heslop. He says, as a researcher in a university, is there a step-by-step guide to how I might link data from a study to patient data in the GNCR?
No, there isn't. Not yet, but that sounds like you could help with a process that we'll obviously need to come up with to make that happen. Yeah.
He does talk,
get in touch, Phil.
Yeah, well, let's see. If I don't know whether Phil's on the Discourse network, but I think that's something really good that we do.
No, that's a really good question.
Forward.
Oh, I didn't realise there was going to be valuable information and questions like that. That's a really good question. But no, the answer is no. We don't have that. Yeah. We don't have that process set up yet, so that all needs to happen.
And it is quite early days as well in terms of the processes and things that we're having to set up, because I know that Lou's looking at sort of a process for people joining the HIE and how we go about actually physically getting particular use cases or particular pathways of care on the HIE. So I know that's a piece of work that you've been looking at. I don't know whether...
Yeah, it's early days, and again we'll post that onto Discourse, because we would really love feedback on that. But early days of designing a process whereby we can align care and clinical content priorities for joining the HIE and support the collaboratives around agreeing what that's going to be. So we'll share those slides and would really love some feedback on what that looks like.
Right, I'll add that to my list of things to share.
But just to further on the research piece, I'm hoping that in a couple of years' time we'll effectively be able to go, Alexa, show me everybody in the North East and North Cumbria with prostate cancer. Okay. And then Alexa, show me everybody in the North East and North Cumbria with prostate cancer who said it's okay to be contacted about research. And a really easy way to get people into trials, for example, like the Salford lung study, where they dropped 80 million quid on Salford, and spent 60% of that on recruitment. We might be able to attract that kind of money into this environment if we get that permission-rich research environment.
So I think the answer to Phil is, it's the process isn't there yet. It will be coming,
and it'll need people like Phil.
It will need people like Phil involved. The next question I would say is for Nick Booth, who's sadly not here.
Right.
Talking about
persistent. It's a technical.
It's a technical one. Talking about a persistent care record. What is the approach of GNCR to facilitating this within the 3 modules you have referenced?
Okay, so we take this cultivational approach. So I think eventually we clearly want to get to a persistent longitudinal care record. I think inevitably that'll be held by the citizen at some point, but I think there's a clear evolution to go through. So at the moment, my record, there's a bit at my GP, there's a bit at Specsavers, there's a bit at my dentist, there's some at the RVI, there's a bit at South Shields General. It's a jigsaw. The HIE is the first step in bringing that jigsaw together. The patient engagement platform initially will be largely about, you getting your appointment by email rather than spending £6 million a year on second-class stamps like we do now in the region. But eventually, that patient engagement platform, not eventually, within a year or two, I hope, that'll be your view into the HIE, which will start to populate with all the various bits of information from around the region. And that will then start to look like a longitudinal record. But I think that's an evolutionary process. I don't think, if you watch that little marginalist video, everywhere that's attempted to go bang, great big national longitudinal care record, that fails. But you can grow things successfully. So we would take that evolutionary process, but yeah, very much where we want to go in the end. Patient health, patient control, longitudinal care record, which will follow them round. A lot of healthcare is inevitably going to go online. There's been a lot of fuss about Babylon, etc. But in order for you to get safe online care, you'll have to have your health record follow you to everybody you go to on the internet for care.
Yeah. This one might be a little bit easier for you.
Right.
How do you continue to build trust with clinicians and citizens?
That's an ongoing program of work. We started with trust, to be honest. We didn't start with the technology. We started with the engagement with the citizens and with clinicians. The whole idea was born out of conversations between clinicians, secondary care clinicians and GPs, just about, wouldn't it be nice if we could share information across these boundaries and save lives, frankly. But the conversations that we have with our clinical community continue. We've recently established a clinical advisory group to decide what will be going first into the health information exchange, and that's region wide. So those conversations continue. We've got brilliant clinical champions in the region who are engaging with their own communities in general practice, in secondary care, and that network of clinicians has largely driven the project forward thus far. In terms of citizens and engagement with citizens, we've done a lot of work in that space, but I think we've still got a way to go in terms of, we want to produce some formal governance arrangements whereby citizens are involved. It's fair to say that our governance at the minute is emergent, and that's partly due to the continuous organisational churn of the NHS. Lansley's reforms gone slightly out of fashion. ICS is busy thickening up into something. But we think we'll need eventually, not even eventually, actually fairly soon, the minute we start to do research, we'll need some kind of citizens council who are overseeing that what we're doing is okay. We don't want to end up in a situation where patients are getting nasty surprises about what's happening with their data. We don't want to be in a position where we lose that trust, because you only get one shot at trust. When it's gone, it's gone.
I know with some of the work that Madeline Murter and her team are doing, they're obviously looking to set up like patient panels who will basically oversee, is this researcher okay? Is this the sort of thing you would expect your data to be used for? So we want to set up that panel. So I know that team are developing that work as well at the moment.
Yeah.
And I think it's a lot of it is it does come down to comms as well, which I would say as a comms manager, is in terms of how what messages we're putting out there. There's a lot of certainly what came out in some of the research was that people don't always realise that information isn't already shared. So we're sort of testing quite a lot of messaging and things like that at the moment with the public, and we do need to sort of raise our profile with the sort of 3.6 million people that live in the region, and we're doing a lot of work on that at the moment. And I think a lot of it is around the fact that we are clinically led, and there's a lot of trust with the public, with clinicians, And I think that's something that we really need to sort of ensure is in our messaging, is that this isn't just, you know what I mean, this is actually doctors and nurses and people who work on the ground think that this is a really good idea to share records. So really it's about putting those messages out as well.
I can add into that and agree with everything. That the really important word, and I think Joe's mentioned this already, is that idea of co-production. And I think on my first day working with Connect Our Cities and the Great North Care Record, it was described as a team of teams. That this is absolutely about reducing the distance between the design and deployment of the digital offer and care conversations, and a phrase we use, the constellation of care, about who is involved with the care of an individual, and with that process, and that's the purpose, and that remains the purpose.
Excellent. Right, just make sure I'm missed anyone off here. When do you envisage the Great North Care Record trusted research environment to go live? 2019 or 2020?
Blimey.
Thanks, Anthony.
Realistically, we've got a lot to do this year. HIE patient portal, 2020, I'm guessing, would be the soonest. There's also that none of this is easy, frankly, but that bit's really quite tricky, and I hear people bandying around phrases like pop health, and I've seen a number of definitions of that now from different people, and it isn't all clear to me exactly what the requirement is and how we would best fulfill it. I also think it might be really quite expensive, and I'm not sure we've got the money for it, but we're certainly working towards it. But this year, in all honesty, no.
And I think, I mean, there's been a lot of work going on around developing like prototyping and seeing how data flows in, and what, you know, I mean, testing that kind of process. So there has been a reasonable amount of work done on that. Well, a lot of work done on that. There are a number of people in the region that are coming together to look at this area and to develop a regional strategy. So I think it is quite emergent, but again, it's very early days with some of this stuff. The care and health information exchange bit and the patient portal bit is imminent. That is all just.
I hope I haven't made it sound like we're not doing anything around that, because people are working really hard on it, and there has been a lot gone on, but it is at a prototype level. And I think it'll be another year before we're ready to go large with that.
Phil's going to help us, which is great. So
magic. Thank you, Phil. Look forward to seeing you.
Mike, as a patient, I want to see my data before I agree to share it. This seems to be something that's impossible.
That's a really good question. And as I said, the mood in the States at the moment is that people are angry about what's gone on at Facebook and Cambridge Analytica and all that stuff, and there's a big groundswell of opinion for patients to be able, A, to see it, and B, to control it, and that's exactly our philosophy. Can you see it now, Mike? Well, you should be able to see your GP record, and quite a lot of detail in there. So I don't know if you've had a chance to go down to your GP and sign up for access. But you should be able to see your GP record in some detail. Obviously, the pain in the neck business of making a subject access request if you want to see your secondary care data is exactly that. It's a pain in the neck, not just for you, but for the hospitals as well. The sooner we get to a situation where you can log in through your patient engagement platform and view everything that's there about you, the better. It's not going to happen this year, Mike, sorry. But the GP bit, you should be able to get that now. Yeah,
and I think it depends, doesn't it, on how, you know, I mean, I know some people, they may only see like the summary parts of the record.
Yeah, well, my GP isn't sharing the whole thing, so I'm going to view the summary.
Yeah.
And you know, I can order online prescriptions and stuff, but my GP hasn't turned on the sharing of the details, which I think is a bit of a cheek, actually. I think that's my call, not his. Well, it should be. At the moment, I think it is his call, but I think that needs to change.
And from what I understand as well with the NHS app, that it'll be summary information that's shared, unless the GP says, yes, you can share the sort of detailed record. So I agree with you, Mike. I think, you should be able to see it. It's a fairly fundamental question because there might actually be things in there that you do and don't want to share, so that it comes down a lot to the granularity of what you can do. And this was something that came out in a lot of the patient focus groups was, well, I might want to share bits of my record, but there might be bits I don't want to share. And
I might also change
share.
my mind further down the line.
Yeah.
I might feel differently in the future. So they wanted to be able to get in, see what's there, and decide whether or not it's shared or not.
So I think, again, that's something that when Joe's talking about sort of starting small and growing it, is that's probably where we want it to be, but it'll take time before we can get to there. And I think one of the things that did come out in some of the subsequent focus groups, there was another couple that were done in the summer, was, well, if I'm not sure, I'm just going to say no, because I can't have the granularity. So yes, I think you've raised a really good point there, and please do keep banging on to the CCG as you make a comment in there about, because it's only by people doing that that things change. So I see a lot of people on Twitter who are very passionate about wanting full access. They want to see everything, and not being able to get that, and
there's a fascinating group of people. I call them the Dropboxers. They're so tired of not being able to share their information that they open a Dropbox account and then they put everything in there. They're people normally with a complicated condition, and so they take their X-rays and they put them in a Dropbox. They put their ECG in a Dropbox, and then they just give the details to the doctor who's seeing them anywhere in the world. And effectively, what they're doing is they're creating their own
PHR
personal health record in Dropbox, and then sharing it with whom they like. I think it's a really interesting model.
Well, that was it. Again, that was something I remember seeing in some of the focus groups. People had quite innovative ways of sharing data because they knew it wasn't shared. So they'd have data sticks or massive sheets of loads of paper with all of the history on. So it's got to get better.
Back in the 90s, there was some really interesting work done about the advantages of using the computer in the consulting room and different models of doing that and turning the screen round and having that three-way conversation and some of the advantages of that. And that was probably before the internet as we know it now. So before that information sharing piece, but some of those principles will still be really relevant and really interesting from back when these opportunities and benefits were first identified, really.
Right, is there a discourse link? I think that's from Phil. Yes, I will send it out to you, Phil, as long as you've registered on Eventbrite. So everybody who registered on Eventbrite will, I'll send you links to those. So Mike's just come back there. Yes, you can see the online coded record.
Same as me there. GP probably hasn't turned on the detail record. They can do that. And do you have a right to insist on that? I'm not sure if you do or you don't.
I've got another question here, which is there a planned supplier engagement for the citizen portal? So
yes,
it's in progress at the moment.
We're writing the spec at the moment, and we're nearly there with it.
I'm not
sure. There'll be much as there was for the HIE. There'll be an almost identical process. Going forward.
And will you look at other examples of patient-controlled persisted patient records within the UK? Like the Care Information Exchange in North West London, to help with the planning of the citizen engagement platform.
Hit me again.
I suppose it's about, whether we're sort of linking up with London, which,
Well, all of the consultation that we've done has been around a regional integrated care record. I think if you've got your permissions model right, there's no reason why a citizen shouldn't say, I want my stuff shared nationally / internationally / published on the side of a bus, if that's what they want. At the moment, we're not trying to solve the national problem. What we will do is adopt any standard that comes out of the centre to make sure that if at some point in the future you want to share your information nationally or internationally, we will be working to the standards that allow that to happen. I'm hoping that development of NHS X will give us that set of, gold-plated standards, the 4 foot 8.5 rail track that will allow us to connect up everything to everything else with your permission.
And a moment to massive shout out to our cousins in Liverpool and Lancashire Patient Record Exchange and who with all good design and consulting models with the HIE joining process that you were describing at the start, Catherine, that was, I think, the first thing that we did. Went and talked to people who've done some of this stuff. So big shout out to, there'll be lots of people that we've not mentioned who are really grateful for.
But yeah, Bristol, Hampshire, Liverpool, Lancashire, Leeds. Who've I missed out? We'll upset somebody, won't we? But, Scotland, Wales,
Well, that's it.
all those, Northern Ireland, actually, really, really helpful people.
Well, that's it, because we're all at different stages in the process of implementing this, and I mean, we're ahead in some ways, but you know, I mean, possibly in some of the sort of social stuff that we've done, but you know, I mean, technically, we're, you know, I mean, we are maybe further behind where some of our neighbours are, so we are having conversations nationally.
But if you need an anthropologist, I've got one.
Yeah, we've got the on-call anthropologist.
And if you know something brilliant that you think that we might not have seen, or that, please put it on discourse. It's absolutely, it's kind of organisation, the broadest term, programme learning in action. So we'd really love to share and discuss anything that you've got that would be fantastic, please.
So yes, I'm just checking on the chat again there. So Mike's having a bit of help about you could change his GP. Might be a bit drastic.
Steady on, Mike.
So does the GNCR envisage the need to upskill both patients and clinicians in using proposed technologies? For example, using and getting benefits of the patient portal?
The answer to that is yes. I think that one of the things that we worry about, as somebody whose 87-year-old mother is currently interacting with the NHS, is we can't leave anybody behind by dint of the fact that they're not very good at the internet or they haven't got a computer. We are the NHS and we don't leave anybody behind. We're pretty good at inclusion, but we will need to help those who can't manage. But I'd like to turn that argument slightly on its head, actually. It's not about excluding people. It's making sure that middle-class owners of iPads like me look after myself as much as possible online, freeing up time for doctors and nurses to help those who aren't so lucky, and to give more time to those who would otherwise be excluded. So I think I think we can have our cake and eat it there, to be honest. But yeah, we mustn't leave anybody behind.
Well, I suppose it's about creating giving the digital option, which isn't there now, for, you know, I mean, it's never going to be for 100% of people, but it's a big chunk of the majority that would be quite happy to transact with the NHS that way. So it's just giving it as an opportunity which isn't there at the moment.
From that practitioner perspective, there's that fantastic slide you've got about what happened when it went to one click.
Oh yeah, the Hampshire Health Records. And whenever I talk about this slide, though, I have to give a mere £10. It's £10. So that's another tenner for a mere in my car. But effectively, the Hampshire Health Record was stuck behind 5 or 6 clicks, and it didn't really take off until the doctors only needed 1 click to view it. And when it did get that right, making it usable, it took off. Its use took off significantly, and we learned a lot from that, and we try to build that Hampshire usability into the Great North Care Record at every stage.
So I suppose from a training perspective for clinicians is that with the HIE, it's not a separate system that they have to go on and then be trained in. It's embedded within their existing clinical systems.
Yeah, so it's a button you click to see the other stuff in the regional information.
Yeah.
So hopefully, in terms of training, there's not going to be a massive.
Nobody had to train me to use my iPhone.
But
we need to think about that level of usability for systems.
And I think it's the same with the patient portal.
It's got to be bright.
And I think when a 3-year-old can pick up my iPhone and use it, and manage to change Netflix channels and various other things, that is how easy it needs to be. So it has to be completely intuitive.
I went to a brilliant lecture in Orlando last week, a big health IT conference, and they had a number of patient designers there, people who were building patient engagement platforms, but literally designed by the patients. And what was interesting was that they weren't at all interested in what the doctors would have put in there. They had a different set of requirements altogether. The best example I can think of was that they wanted to know about how to park when they got there.
That's it, where to go, what change do I need for the machine?
All of that stuff. So it wasn't all, all about medicine or clinics, or some of it was really basic stuff like, how will I find my way to the right counter? Where can I park my car? Can I park the car? How far does you have to walk with your broken leg from the car park to the fracture clinic? Important stuff that probably secondary care doctor like me is not thinking about, sitting in the clinic thinking about where are they, not thinking about how they parked. So citizen design into that process is going to be really important.
And I think that's something that will continue, is that as we develop the patient portal, we'll be going back out to the citizens that we've engaged with previously and testing it. Is this how you expected it to be?
Yes.
Does this make your life easier? So it's not, it is going to be an iterative process. And again, like we talked about, sort of co-design and co-production. I don't have any other questions on there. I apologise if I've missed anybody off. I'll just have a quick scan through, because just to make sure I haven't. Was there anything else that you wanted to add, or?
I think we're at the most exciting point of this project now, actually, because literally within weeks, the Health Information Exchange will be announced. That will begin to move information around the region for the point of care at an entirely different scale to what we've done before, and puts us into, because of all the nature of the different systems, this will be the most disparate but connected health economy in the world in terms of the number of different systems that will be connected up, and will really put the Northeast and North Cumbria on the map. I'm really excited about the patient engagement platform as well, not least because we do spend £6 billion a year on stamps, and I want to see that gone in the next 18 months, 2 years.
Excellent. So what we'll do, we'll wrap up there, but we've recorded this session, so we'll share the link to that. We'll share Joe's presentations. We'll share the discourse link for anyone that isn't already on there. Thanks so much for sort of dialing in and getting into the presentation. We'll also send out a little survey afterwards, because this has been the first one, just to sort of see whether Zoom worked for people, were people unable to connect or anything like that. So we'll try and just get some feedback from you on this as well. So thank you very much, and we'll hope to see you again soon. Thank you.
Thank you.
Bye.